Hey everyone, welcome to This Explainer. You know, childbirth is usually this beautiful, highly anticipated, and honestly pretty standard medical event. But what happens when the predictable suddenly becomes precarious? Today, we're diving straight into the high-stakes reality of the delivery room. We're going to explore just how fast a routine labor can escalate into a massive medical crisis, where literally every single second matters. And we'll see exactly how medical professionals are trained to catch those silent alarms before it's too late. Let's get into it. Here's our roadmap for today. 1. Navigating difficult labor. 2. Severe uterine complications. 3. Amniotic fluid embolism. And 4. Managing fetal cord emergencies. All right, kicking things off with Section 1, Navigating difficult labor, specifically when progress just stops. So in clinical terms, a complete stall like this is called obstructed labor. And the key phrase you really need to focus on here is insuperable barrier. I mean, this isn't just your run-of-the-mill slow labor. We're talking about a total mechanical failure. Despite having strong, perfectly effective uterine contractions, the baby just cannot advance. It's like the engine is revving, but the vehicle is completely blocked. Now, what's really fascinating in the clinical notes is how medical professionals actually sort the root causes of this barrier. They put them into two main buckets, the passage and the passenger. So a fault in the passage, that might be a contracted pelvis, or maybe pelvic tumors are blocking the way. On the flip side, a fault in the passenger could mean you have a really large baby, or what's known as malpresentation, which is when a brow or a shoulder tries to enter the birth canal first instead of the head. Recognizing this blockade early is, well, it's absolutely crucial. The early warning signs include the baby's head failing to enter the pelvic brim, or just really slow cervical dilation. But as the clock keeps ticking, the signs get pretty dire. The uterus might start molding tightly right around the fetus without relaxing between contractions. And most ominously, a visible indentation called Bandel's ring might actually show up right on the mother's abdomen as that lower segment of the uterus stretches dangerously thin. You have to remember, obstructed labor is a dual patient emergency. 2 lives are on the line, and the dangers strictly parallel each other. For the mother, the risks compound rapidly, from exhaustion and sepsis to catastrophic structural tears, like a uterine rupture or fistulas. And mirroring this, the baby's facing immense physical pressure. That can lead to severe asphyxia, devastating intracranial injuries, or tragically, even intrauterine death. Moving on to Section 2, Severe Uterine Complications, looking at rupture and inversion. First up, let's distinguish between 2 types of uterine tearing. A complete rupture is a violent, catastrophic event. It's a full tear straight through the uterine wall and its outer covering, which can literally expel the fetus out into the abdominal cavity. Compare that to dehiscence, which is an incomplete rupture that often happens along an old cesarean scar. Dehiscence is tricky. It's this insidious, quiet danger. The scar opens up, but the fetal membranes actually remain intact, so it often goes completely unnoticed until after the delivery. But if a complete rupture happens during labor, the diagnostic checklist is terrifying, and it's immediate. The mother might suddenly collapse, complaining of intense, severe abdominal pain. Her heart rate skyrockets. But strikingly, those strong uterine contractions we talked about, they suddenly cease entirely. And shockingly, the actual shape of the fetus might become palpable right under the skin of the abdomen because it's slipped outside the uterus. Another severe structural failure is acute inversion of the uterus. This is a rare, super life-threatening complication that happens during the delivery of the placenta, where the uterus actually turns inside out, protruding into or even out of the vagina. And this really highlights the delicate nature of obstetric care, because get this, it's frequently caused by well-intentioned but improper medical management. Usually it's from pulling way too hard on the umbilical cord, or applying too much downward pressure to the top of an uncontracted uterus. When inversion happens, the response has to be explosive and decisive. A midwife or doctor will often deploy what's called the Johnson's maneuver. Step 1, summon help immediately. Step 2, the practitioner has to physically push the inverted fundus with the palm of their hand up along the vagina towards the back wall. Step 3, they lift the uterus back toward the umbilicus using steady, firm pressure. And finally, they literally have to keep their hand firmly in place until they feel the uterus contract tightly right around it, which secures it back in its proper position. Okay, Section 3, Amniotic Fluid Embolism, a systemic shock. An amniotic fluid embolism, or AFE, is a true nightmare scenario, mostly because of its sheer unpredictability. It happens when amniotic fluid, which is packed with a clotting activator called thromboplastin, is suddenly forced into the mother's bloodstream through the placental site. The mixture of this fluid in the mother's blood triggers an instantaneous, massive cardiopulmonary collapse and severe bleeding disorders. There is zero warning. The clinical notes document the absolutely terrifying speed of this syndrome. They map out exactly how rapidly an AFE destroys the body's internal stability in this rapid-fire, cascading chain reaction. So let's break down this cascade into its 4 phases. Phase 1 is immediate: pulmonary vasospasm and cardiac collapse. Basically, the mother suddenly cannot breathe and her heart fails. Phase 2 quickly introduces severe hemorrhage. Then, by phase 3, a condition called DIC sets in, which means the blood completely loses its ability to clot. None at all. And finally, phase 4 brings uterine atony, where the uterus completely refuses to contract, leading to torrential, totally uncontrollable postpartum bleeding. This brings us to section 4, managing fetal cord emergencies, a true race against time. When it comes to the umbilical cord, medical teams have to distinguish between 2 conditions. First is cord presentation. This happens when the cord lies in front of the baby's head, but the amniotic sac, the membranes, are still safely intact, which protects the cord from being crushed. But cord prolapse, that is the immediate life-threatening emergency. This is when the membranes actually rupture and the cord drops down in front of the baby. Once it's there, it's going to be relentlessly compressed against the mother's pelvis with every single contraction. So what actually causes the cord to slip down in the first place? Well, it generally happens when there's just too much empty space in the lower uterus. If the baby's head is ill-fitting, or say the mother has had many previous pregnancies, a term called multiparity, leaving the tissues lax, space opens up. Complete breech presentations, face or brow presentations, or having an excess of amniotic fluid, known as polyhydramnios. All of these can create the perfect storm for the cord to wash down the second the waters break. And when a cord prolapses and gets completely compressed, shutting off the baby's oxygen supply, the clock starts ticking loudly. According to medical texts, the fetus has a maximum of just 10 minutes. That's it. 10 minutes to survive complete cord compression before permanent hypoxia, severe brain damage, or stillbirth occurs. 10 minutes means immediate physical intervention to literally fight gravity. The team has to quickly reposition the mother into an exaggerated Sims left lateral position with her hips jacked up on pillows, or into a knee chest position. And at the exact same time, a medical professional must insert sterile fingers to physically push the baby's head up and off that cord. And they have to maintain this manual elevation nonstop. I mean, even in the back of a speeding ambulance, they are holding that position until they reach the operating theater for an emergency C-section. And that brings us to the end of our triage arc. We've seen how a stalled labor can escalate to a ruptured uterus, how a systemic shock can take over a body in literally seconds, and how a prolapsed cord gives a medical team just 10 minutes to act. The sheer intensity and the raw skill required in the delivery room are honestly awe-inspiring. So I'll leave you with this thought. In high-stakes obstetrics, where mere minutes or even seconds separate life and death, how crucial is the deep structural knowledge of these silent warning signs before they become irreversible crises?